Good morning, everyone. Thanks for joining us today for a women's health webinar. Um, we do have a partner with the Banner Medical Group, Sarah, joining us today to present kind of everything women's health related. So Sarah, I will turn it over to you.
Okay, terrific. Thanks so much for inviting me to be here today. Hopefully, I can give you some insight as a glossing overview of women's health today, kind of a big topic. My name again is Sarah Schutte. I am a physician, OBGYN physician with Banner Medical Group. I practice primarily out of our office on Lady Moon Drive in Fort Collins. We also have an office in Loveland, and then Banner Medical Group has a third office in Greeley, but I don't practice out of that office. So my task today was to go over women's health basic screenings, and then add in a little bit of information about perimenopause and menopause. So we'll just move through these slides. At the end, there'll be time for questions if anybody would have any. We can go to the next slide. So first thing we always think about is screening. As a physician, when patients enter into our office, whether they're presenting for a wellness visit or annual exam, as it's often called, or for a problem visit, we always focus on the general screenings, which should be done throughout the span of life, trying to educate and then also, follow up and encourage the directions to go to get those screenings. Next slide. This is going through, again, what we're going to pass over, perimenopause and menopause, and then questions. Next slide. So in terms of screening, there are two major recommenders of what screening should be provided to women. The United States Preventative Service Task Force does preventative services or screening for men, women, and children. And then the American College of Obstetrics and Gynecology regularly updates women's preventative services guidelines. So in my line of work, I'm focusing on women's preventative services and what the current updates are. It's nice that these central powers put out this information with the hope being that it's evidence-based recommendations for screening that then all providers of women's health or healthcare in general can fall back on as to how to screen, and therefore our whole population has available to them the best information. Next slide. So the first thing that we look at, again, now we're honing into women's health particularly, is general wellness. Through the reproductive years, which can start as early as 13 or 14 and go on until menopause, we often, and people think of their OBGYN as focusing on contraception. Another thing that both the US Task Force and ACOG focus on is folic acid supplementation. The current recommendation is that anyone who's reproductive age, even if they're on contraception, be taking 400 to 800 milligrams of folic acid daily. Next, blood pressure and cholesterol. Everybody recognizes when you come to the doctor's office, they're typically going to check your blood pressure. And we do that. The recommendations for blood pressure are beginning early in life, as early newborns get blood pressures, but then age 3, every 3 to 5 years, checking in on a blood pressure if it's not elevated. And then after age 40, we do that annually. Cholesterol probably beginning again in the childhood years and the pediatric years, so up to age 18, this should be initial screen, and then probably every 3 to 5 years, assuming it's normal, and becoming more regular as we age. Diabetes screening and prevention, typically we start screening more like age 35, goes on through the span of life as diabetes risk increases with age. And prevention is going to segue into the next general wellness, which is diet and exercise. We can't prevent our genetics, but we can adjust our genetics by staying in that body mass index, or BMI, which is considered to be optimal or as close to optimal as our biochemistry allows us to be. and exercise that's appropriate to our medical wellness and age. So that kind of counseling comes into just a routine visit as well. Urinary incontinence, now we're getting down to issues of women's health typically, but urinary incontinence is more frequently found than expected. And it's on our general wellness because for many years it wasn't something that doctors asked about or patients wanted to speak about due to just the private nature of that issue. So we make it a part of our general wellness so that it's a question that's asked so that patients can feel free to bring up issues with urinary incontinence or loss of urine when you don't want to lose urine. Mental illness and safety is a big thing. Uh, Sorry, lost my words. Interpersonal violence is safety. So we always want to ask whether people are safe in their environments. Again, another question that hasn't traditionally been asked in medicine, but the US Task Force and ACOG are really pushing that we make sure that our patients are in a safe situation. And being in the doctor's office is a time where we can ask those questions and help to address them if need be, typically by referral. And then mental illness, again, depression, anxiety are becoming more and more prevalent in our society and are something that we want to ask about and address as we're able. Substance use counseling, from tobacco through alcohol to illicit drug use, or now not illicit, but regular use of marijuana, how those things enter into wellness, and the reproductive years is something we always touch on. And then in the aging populations, osteoporosis, which becomes more frequent as we age, and particularly more frequent in menopause, and then fall prevention because of aging and increased issues with balance as we age. Next slide. So moving on to infectious diseases, OBGYNs, obviously one of our primary infectious diseases that we're screening for, sexually transmitted infections, gonorrhea and chlamydia. The current recommendation is in everyone age 13 to 24, they should be screened annually. After that, it's more based on risk or symptoms. Hepatitis B and C, also in reproductive years, we're testing with pregnancy, but it's recommended to screen these things again beginning at age 13 and following throughout the life cycle based on risk factors. Syphilis, I don't know whether it's typical that in the news, syphilis has increased nationwide and including Colorado. So we have really upticked our screening for syphilis. Speaking particularly for pregnancy, we now check for syphilis 3 times throughout a pregnancy because the prevalence has increased so much, including in Colorado. HIV screening, again, through the reproductive years. We used to think that this was just a screen and not much to do about it. They now have something called PrEP, which is preventative treatment if a patient is in a particularly high risk situation to be exposed to HIV because of a known partner or because of risky behavior. So again, we want to screen with those questions each time people come in. And then tuberculosis, we're familiar with getting that tuberculosis time test. That begins about age 13, not particular to OBGYN visits, but again, in the general wellness, and the US Task Force focuses on tuberculosis. Next slide. Cancer screening, we'll have some input from Rachel or our leaders about what your benefits are. But for breast screening, interestingly, everybody comes in with our indoctrinated self-breast exam, which we originally were advised to do each month. What they found with that is that there were much more screening done because of intermittent self-breast exam and then confusion as to what's normal. So they've changed the recommendations for patients to be, quote, breast self-aware. And what I typically tell patients is, what is that? But if you thought of being, aware of the back of your hand, if I put a new lump on the back of your hand, or you got a new lump on the back of your hand, you don't do a back of the hand exam. But as you function throughout the day, you would notice that. And so breast self-aware means we shower, we put on bras, we feel a tweak or a pain and feel at that spot. And if something comes up in just functioning through your day and normal function, then you would present to your primary care provider or to your OBGYN. In terms of mammogram screening, the current recommendation varies a little bit by who's making the recommendations, but is basically every 1 to 2 years after age 40 based on risk factors, and then annually at age 50. Did you want to have input then on the mammogram coverage?
Yeah, I definitely can jump in here. We do have just a reminder there on the box on the left-hand side. First mammogram is covered per calendar year at 100% on our plans. And we actually don't have any age restrictions on our current plans. So if you are someone, maybe have family history, whatever the case is, you do not have to be over age 40 for our plan to cover those mammograms, whether they're routine or diagnostic.
That's terrific. I will input also that frequently diagnostic mammograms aren't covered by plans initially. So that's a great benefit to be able to have that covered, because when your screening mammogram is abnormal, or when we find a lump or a patient finds a lump and we want to do a diagnostic mammogram, there are plans that don't cover the diagnostic. So that's a terrific benefit. In terms of cervical cancer, this has changed again. Guidelines used to be when you first saw a gynecologist or got a period, you often got a pap smear, or if you were started having your periods, you were thought to get a pap smear. Then it became when you were first sexually active. Now it's been pushed off until age 21. And that's with the reason that we have learned in the last 20 years that cervical cancer is basically a sexually transmitted disease caused by vast majority of cases, greater than 95%, the human papillomavirus or HPV virus. Much of the exposure to HPV when we are younger will be cleared, even if it leads to cellular abnormalities which are not cancerous, they typically will clear. So that in order to avoid treating something which is going to clear on its own, that's why the guidelines have been put off to age 21. So from age 21 to 29, you can see there the recommendation for a pap smear, assuming they're normal, is every 3 years. At age 30, we begin to do the routine pap smear, but we also add in human papillomavirus testing, which looks for exposure to the high risk, which means high risk of leading to a cervical cancer, subtypes of human papillomavirus. When a pap smear is normal and the human papillomavirus testing is negative, pap smears are only done every 5 years after age 30. Pap smears in general, routine coverage stops at age 64 or with the onset of Medicare at age 65, unless there is a high risk situation, in which case they'd still be covered and recommended. Gardasil is the vaccination which came out on the order of 20 years ago for human papillomavirus. It has advanced during that time. Initially, it was against 4 subtypes of human papillomavirus, of which there are probably 100. The 4 subtypes included the 2 which are most highly associated with cervical cancer, as well as the 2 which are most highly associated with warts, which are genital warts. Since that time, the Gardasil vaccination now it has 9 different subtypes of HPV against which it protects, and also has some scatter to protect more widely than that. Gardasil can be given in the pediatric years, and that's the recommendation because it's most effective if it is started before sexual activity. It is a one-time series of 3 shots. Which can be picked up if there is a hiatus between shots 1 and 2 or shots 2 and 3. It can also be given now up until age 46. And so often that is covered later in life, and many patients who are a little older miss the time when Gardasil is given in the pediatric population. Next slide, please. Familial cancers. So in the OBGYN office, we focus on breast and ovarian cancer genetics. There's the BRCA gene mutations, which increase family history or family risk for breast and ovarian cancer, as well as colon, prostate cancers, and uterine cancers. And so when a patient comes in, we do ask a family history and get particularly a family history of cancers, as well as the other diseases that may run in families and give a genetic predisposition to either cancer or other medical issues. Um, when I started in medicine, which was a few years ago, these were things that we didn't often want to know because we didn't think there was anything to do about them. But we now do have heightened screening, which means that you can catch cancers earlier. And as Rachel suggested, even if a mammogram was recommended before 40, you have a plan that would allow that to happen. And then there also is risk modification based on what contraceptive method you choose and whether how you choose sterilization techniques. So now, if we used to quote tie fallopian tubes for sterilization in women, which meant we removed a portion of the fallopian tube. It's been found that ovarian cancer probably begins in the part of fallopian tube which is closest to the ovary. So in patients with a genetic predisposition and not, we can remove the entire fallopian tube and decrease lifetime risk of ovarian cancer. So there are interventions that can be made when this information is available. So we always screen to see whether there's any heightened risk and therefore need for heightened screening. Next slide. Other cancers that we typically discuss, colon cancer, we can have genetic predisposition to, but in the routine patient without any genetic predisposition, the recommendation has moved from 50 to 45 to do a colonoscopy. Skin cancer screening actually begins early because it's prevention is the number one. It's one of the most common cancers now, not necessarily the most common cancer to die from, but it's common because of our tanning and lack of sunscreen. So preventative counseling begins early with that and continues. And then lung cancer remains primarily smoking associated. A patient who has a 20-year history of smoking will have heightened screening for lung cancer. Rachel?
Excuse me, sorry. I was just going to state here, this plan, colonoscopies are run just a little bit different than mammograms, mainly for our HDHP plan members. But if it is just a screening and no biopsies are taken, for high deductible plan members, it is covered at 100%. If there is a biopsy obtained during that colonoscopy, you will pay the full charge of that colonoscopy. So, and then for our PPO plan members, either standard or choice plan, whether it is preventive, diagnostic, there's a biopsy or not, your first colonoscopy of the year is always covered at 100%.
Terrific. Next slide, please. I think this is also you, Rachel. Are you there, Rachel?
I was talking away. Didn't realize I had muted myself. I apologize.
Yeah.
Yes. So happy to take this one. This is just kind of going back to our partnership that we have with MD Anderson and Banner there in Loveland and in Greeley. So this is just kind of reminder to everyone. If you or someone covered on our medical plan is diagnosed with cancer, keep in mind that if you do seek treatment at either the Greeley or Loveland MD Anderson, 100% of that is covered. So you don't have to meet your deductible first. I know that's a number one question that we get in our office is, do I have to meet my deductible before that is covered? It is not. 100% for Greeley and Loveland. So choice and standard medical plan members only, but it's a great partnership that we have. Anyone have any questions on that?
I'll add that MD Anderson has been a great addition to Northern Colorado, and has been expanding for the years that it's been here now. So we're really happy to have that partnership, as MD Anderson is one of the top cancer centers in the United States, and we become able to participate in their research protocols and more advanced treatments of cancer than might be possible in Northern Colorado because they're here. So that's a great availability to all of us.
Yeah, and I think I was recently informed too that all of the each case is still run through the main HD MD Anderson down in Texas. So it's not just you're kind of on your own island here up in Greeley or Loveland. It truly is a group effort with everyone. So
Yeah,
it's been a great partnership so far with us too.
yeah, absolutely true. So then moving on to the concept of menopause, a lot of um, people have questions about what is menopause and what are these different terms. Um, the ones that you'll hear are perimenopause. Peri means around, menopause, and then postmenopause, which means after. And in the OBGYN's mind, I think these may be different than you hear in just lay literature or on TikTok, as it were now. Next slide, please. So perimenopause is the time around menopause. Maybe it would have been wise to define menopause first, but menopause we think of as the stopping of your menstrual cycle. The transition to menopause is probably a 10-year transition. The difficulty is there's no blood test to say you're in perimenopause. But patients notice a lot of changes, which clue them into something's going on. I think the most um, highest prevalence in that time is a change in menstrual pattern. This change can be an increase in bleeding, a decrease in bleeding, an increase in frequency, a decrease in frequency, but a change. And then the other thing that is often noticed is mood changes, particularly our premenstrual mood. So from ovulation until the period starts, or the second half of your menstrual cycle monthly, a greater prevalence of mood changes is noted. These are things that there are ways to address. Certainly, a change in menstrual pattern you want to address if a patient is having bleeding which is too close together or too prolonged. It can lead to other medical issues, but it can also be a sign of not just the normal transition, but of something else going on. So we typically will look into that. In terms of premenstrual syndrome and mood, we also try to address those changes as we can to as a patient feels is necessary. Next slide. So menopause is defined as 9 to 12 months without a period. This can't be when a patient is on a hormonal contraceptive or treatment to try and stop their periods. That will sort of block our way of knowing when we're in menopause. So 9 to 12 months without a period would be the definition of now you've reached menopause. At the 6 month without a period, it doesn't mean you're not in menopause, but we can't say for certain that it's menopause until we've made it to that 12-month time frame. During, menopause, now in a patient who has stopped her period, again, at 6 months, these things could be going on. We wouldn't necessarily say it's for sure menopause until you've made it to 12 months. But weight changes become an issue. Typically, central weight gain becomes a problem with or without changes in diet and exercise. Mood changes, often an increase in anxiety and or depression can happen with the onset of menopause. So we see that frequently. And I always encourage my patients, well, let's look at where you are. Could this be related rather to hormonal changes than really a new onset of mental illness? And then joint pains is a new one. It's been out there for a long time, but was always discounted. This is often, my left shoulder hurts and I've stopped having periods and I'm having hot flashes. There is new data which suggests that the treatment of menopause hormonally may help joint pain, which previous was thought to be unrelated to menopause. So interesting. I didn't include in this talk what are the potential treatments for menopause. The lack is of hormones. So the typical answer is to jump to hormones, but there actually are a lot of non-hormonal treatments which can manage one or all of the symptoms a patient is having. So in that wellness visit, when a patient comes in and we go through all those screening things that we talked about earlier, we'll also be screening for where are you in your menstrual life. Are you, pre-menarchal or haven't yet gotten your period? Are you in the years of reproduction, which is the years when you're having a regular period, or are you in the years after, or in that transition? And then how to address the needs of each particular patient in those times. Next slide. Postmenopause. So these are the typical hot flashes. Now, postmenopausal, it isn't as though menopause and postmenopause are different. They're often thought to be different, but really, once you've stopped your periods, you have the onset of the symptoms, which will then go on. Many patients are most symptomatic in the first 4 to 5 years after menopause. Some patients continue to have disruptive symptoms after that. So we typically think if symptoms are disruptive to an individual patient, that we would initiate treatment with a plan to be for 4 to 5 years and then consider tapering off. The symptoms that are most commonly brought up are hot flashes during the day and at night. Ultimately, though not initially, vaginal dryness because of the lack of estrogen, mood changes, as I alluded to in the menopause slide, osteoporosis, which we discussed in the general screening. Estrogen is protective of the bone, so once we lose estrogen is when we begin to drop down in our bone density. Bone is actually laid down up until about age 24, then is fairly stable in a menstruating female, assuming she's getting enough of the building blocks to keep her bone density that was laid down initially, and then starts to drop off when she loses her estrogen in menopause. And then the joint pains can continue to be an issue for some patients. I would say the data isn't out whether this is, again, a transitional 4 to 5 years time frame or something that could go on if it wasn't managed. Again, we think about hormones as a way to treat, but hormones also can incur risk. Hormones are not a fountain of youth. They will not keep a patient younger, but we do consider them as a option for treatment for these symptoms that are listed, and then try to be on the lowest effective dose and taper that down as the 4 to 5 years have passed to see whether a patient can do well without them. The biggest risk with hormone replacement, everybody saw back when the study came out in 2001 that hormones equals breast cancer. That wasn't exactly what the study said, but that's what the newspaper said. The increased numbers were 8 per 10,000 per year increased risk in breast cancer, and an 18 per 10,000 increased risk in stroke. Those are real risks, but they're small, and they became obvious after 4 to 5 years of treatment. There were some flaws in that study, which we won't go into, but those numbers in a patient without other risk factors for breast cancer or stroke still leave a door open that might be a viable option for treatment. When it's not because of risk factors, then, as I said, there are other ways to try to manage these symptoms without hormones and therefore without the potential increase in risk. Next slide. I think that's what I had. These are our physicians. So because of our partnership, we wanted you to see our OBGYN providers. We have 4 doctors, 3 advanced practice providers, and then on the next slide, we also have 5 midwives who work with us doing both gynecologic and obstetrical care. We function as an integrated but separate practice. So our patients can come in and choose to see a midwife or choose to see one of our docs or the nurse practitioner, physician's assistants who work with us. However, we cross between the 2 practices very smoothly. So if one of our nurse midwife patients needs to have a surgery or transitions to a higher level of risk, then they transition easily because we're all in one office. And those are our locations. The 4700 Lady Moon was there, and then the Loveland location, which is on Boise Avenue, adjacent to the McKee Medical Center. All right, that is it. Does anybody have any questions for me on any of that screening or the menopause, perimenopause, or Banner Medical Group and what we have available to you, or for Rachel on your benefits?
Yep. Thank you, Sarah. I was just going to add that if you guys have any questions for us here on the benefits team as well, happy to answer those. We have chat open, so I will watch for that. But if you don't have any additional questions, we appreciate your time. Thank you, Sarah, for coming on and talking through this with us. I think that this has been very beneficial.
You're very welcome. Thank you for having me.
Yeah, here's one question. You mentioned other options for menopause besides hormones. What are some of those?
So, without getting into too much detail, we use some serotonin reuptake inhibitors, which have traditionally been used for the treatment of depression, have now been studied and shown that those increase in serotonin levels really help with some of the hot flashes of menopause and obviously can help to address some of the mood changes. There are also some medications which were traditionally used for high blood pressure, which have an added benefit of potentially being helpful for hot flashes. Again, we think of these things in terms of patients who have risk factors that keep them from using hormones. And then finally, there are selective estrogen receptor modulators, which have been used initially in the treatment or prevention of recurrent breast cancer, but are helpful in some for some of the symptoms of menopause. And then finally, there are natural products. We use a product called Relazin, which is bought online and is based on the pollen of a particular Swedish flower and other non-hormonal natural substances. There are many things at the health food store which you'll see. Unfortunately, not all of those have actually been studied. So we try to stick to things which have been studied so that have evidence to suggest that this would be helpful. There in menopause has been shown to be a lot of what they call placebo effect, which means you take a medication and you feel better, but it might not be the medication which is making you feel better. Other questions?
Did have one other question come in. How much does menopause play into memory loss? If I don't write it down, there's a good chance I will never remember it again.
You know, I think that's something that's still out. The data is conflicted on whether or not estrogen helps in the prevention of dementia. There is certainly some data which suggests that it does, but there is other data which suggests that it doesn't. It is not currently recommended to give estrogen or hormone replacement for prevention of dementia in a high-risk patient. I think that one of the highest areas of research, we have to recognize that the baby boomers have gone through menopause, and they are a vocal group of women who fortunately have pushed for answers and continue to push for answers through the phases which they are in. And the phase they're in right now is menopause. So there is a lot of research being done, and hopefully, each year we get new information. I always think that that's one of the reasons that my patients come to see me annually, because I'm listening for the information and can digest it and say, no, this or yes, that. Obviously, I don't know everything, but my job is to stay abreast of what's coming up new in treatment of women's health. So I think that's how we can be helpful. And then we also learn a lot from our patients who come in and tell us what they're experiencing, like the joint pains. I've had a patient years ago who came in with complaints of menopause and mentioned that her left shoulder was hurting. And I discounted that and told her about her symptoms of menopause and that we should try her on hormone replacement to see if it would help. We did. She came back, and her first glowing report was that her left shoulder was better. And I was, interesting. And what about the other symptoms? So we do learn from our patients. And so the conversation back and forth and our learning how to be better wellness providers by asking questions, I think has been a great thing for women. Other
Right.
questions?
Yeah, two more. Uh, First one, if you are on medications that eliminate a period, are there tests that can be done to determine if you are in menopause, or do you just have to look for other symptoms?
There are tests that can be done. The difficulty is if we are the patient who's not on any hormonal suppression, uh, and it's been 3 months since I had a period, and we draw my blood, it will look like I'm in menopause if it's a month where I'm not going to have a period. But for the sake of argument, if in the 6th month my ovaries going to say, "Oops, I should have had a V8 and put out an egg," and I have a period, in that month it would not look like I'm in menopause. So that's the difficulty. If a patient has, for instance, an IUD in, there are lab tests that we could do that would look for menopause, but if in that month it shows menopause, we don't know where she is in terms of 9 to 12 months without a period. If it's actually month 3 and she was destined to get a period at month 6, and we took out that IUD, she could have that period. So it's a little bit confusing when you're on suppressive medications, but we try to put everything together. There are some blood tests to do and education on what that might look like to try and get the best information we can.
Great. Looks like we've got one more. What can I do during premenopause to alleviate symptoms?
So it depends on what the symptoms are. Often in perimenopause, the hot flashes are worse than they are for some patients in menopause. Giving hormones in perimenopause, however, can cause issues with abnormal bleeding that potentially lead to trouble that needs surgical addressing or other treatment. So we want to be a little cautious with hormonal treatments. The contraceptive hormones are actually higher than your body would make. So going on birth control pills sometimes will level that for some patients, but we don't love birth control pills in the 40s because of potential risks which increase in our 40s. There are some of those natural supplements that have, the pollen of the Swedish flower, the gel from a queen bee, that actually have data that are helpful. And then the last for the mood changes, and as we heard earlier, sometimes some benefit in hot flashes are the serotonin reuptake inhibitors, which can be taken just in the second half of the menstrual cycle. So for 2 weeks out of the month, you're on that, but not for the whole time. It depends on the patient. Some patients prefer natural. Some patients would love to just have hormonal treatment, and some patients, are comfortable with being on what is traditionally thought of to be an antidepressant, and others vary. But there are things we can do. Other
Right.
questions?
One more came in. What can we change in our diet to help with perimenopause and menopause?
Shoo. I am with everyone who is perimenopausal or menopausal on what is the best diet. And unfortunately, anybody who ever opens social media finds 10 different answers, all of which you require a 45-minute video to watch, and then, hundreds of dollars to buy the magic supplement or the magic diet plan. I think Western medicine doesn't know the answer to that question. When we can partner with naturopathic medicine, I think, perimenopause or menopause is a normal process, but what it comes off in us is often an imbalance of wellness rather than an illness. And I think Western medicine is much better trained at treating illness than imbalances of wellness. So I think getting regular exercise, a healthy diet, which is more towards protein than carbohydrate, paying some attention to caloric outlay, meaning exercise and just activity throughout our days relative to caloric intake, empty calories, alcohol, and desserts are things that we should try to avoid. If we think about our metabolism as a woman who's a teenager and has the turning on of her system, most women experience a time of their weight being out of control, meaning my weight was I could eat whatever I want, and now all of a sudden I have gained weight that I didn't want to gain. Then between, that onset of the system and the turning off of the system, we usually find a set point where if I eat this much, I weigh that much, and if I overeat, I can do that and lose the weight. And that set point changes with menopause. So that's frustrating. We have to, it seems, eat less and exercise more to keep our weight the same. And I think there probably is something dietary in each person which can help that. But I think it varies. I don't think there's a magic diet. And I think that the internet is really making a lot of money on it. So I don't really espouse um, listening to each one of those videos and buying in. But I do keep my ear to the ground because, when we come up with something that is universally applicable, I think it will be a wonderful thing. And I think there is a lot, again, of research looking into this. But it is a very common frustration of this change in metabolism without really changing what you've been doing. Any other questions?
That looks to be it for right now.
Great. Well, this has been
Sounds
fun. Thank you very much for having me.
Yes, we appreciate you joining. Thank you, everyone, for joining. And we will end the webinar. Everyone, have a great day.
Thanks so much.
Thank you. Bye bye.